Hello, everyone. Thank you all for joining today. I think it's time for us to get started. Um, Thank you all for joining today's webinar, Equity in Action, Local Strategies for Reaching Zero-Dose Children and Communities. Please continue to introduce yourselves in the chat, your name, country, and role, so that we can all get to know each other over this next hour. My name is Erin Brookhazen, the project director for the Gavi Zero Dose Learning Hub at JSI. It's a pleasure to have you all join us today for the first Zero Dose Learning Hub 2024 webinar series webinar. Today, the Zero Dose Learning Hub highlights the work from 4 country learning hubs in Bangladesh, Mali, Nigeria, and Uganda to use evidence to better understand the factors influencing implementation and performance of approaches to identify and reach zero-dose children and under-immunized children in missed communities. Next slide, please. Before we get started, let's take care of a few housekeeping items. For those of you who would like to continue the webinar in French, click the interpretation icon to set your channel to French. Those who wish to stay with us in English, you will also need to click the interpretation icon to set your channel to English, as we will have interpretation from French to English, and you'll need to have selected that audio channel to hear it. Pour écouter le webinaire en français, cliquez sur l'icône d'interprétation pour sélectionner le canal audio français. Ceux qui souhaitent écouter le webinaire en français devront sélectionner le canal audio anglais. Next slide, please. Please submit your questions for the panelists in the Q&A box. Panelists will either reply back to you via text in the Q&A box, or will answer your question during the discussion portion of the webinar. Next slide, please. If at any point during the webinar you are unable to hear, please make sure you're connected your audio by selecting the headphones icon at the bottom of your Zoom window labeled Join Audio. If you still cannot hear the presenters or see the presentation, try leaving the meeting and joining it again with the link provided. Please send a message to everyone to send in your questions or comments for today's speakers. We really want to hear from you, or ask for support during today's webinar. We have a support team monitoring the chat and able to provide future assistance. Closed captioning in English has been enabled for this meeting. To view the live English subtitles on your screen, click on the CC icon for closed captioning and select Show Subtitle. Please note that this meeting is being recorded, and the recording will be shared via email and will also be made available on the Gavi Zero Dose Learning website. Next slide, please. Now it's my pleasure to introduce our facilitator for today, Dr. Heidi Reynolds. Heidi is a senior specialist in evaluation and learning at Gavi, the Vaccine Alliance. Heidi has over 20 years of experience in health information system strengthening, measurement, evaluation, and research, and she oversees the Gavi Zero Dose Learning Hub initiative, including the Zero Dose Learning Hub project, as well as the 4 country learning hubs in Bangladesh, Mali, Nigeria, and Uganda. Without further ado, I'd like to hand it over to Heidi to introduce the panelists. Thanks so much, Heidi. Over to you.
Thanks, Erin, and welcome to everybody here today. As Erin mentioned, this presentation is one of several activities that take place within the overall Learning Hub initiative, which runs through the year 2025. I invite you to follow our progress through the website that Erin mentioned and will be posted in the chat later, as well as the Zero Dose Community of Practice. Today, the work here is going to draw on the experience and expertise of the networks of providers and other professionals working in the space to reach children without immunization and other services. These conversations have yielded important insights about the challenges and promising practices in order to reach zero-dose children who have never had immunization. And with that, it's my pleasure to introduce the Geneva Learning Foundation, whose names and voices will probably be very familiar to many of you. First up is Reda Sadki. He is the president and CEO of the Geneva Learning Foundation. And then we have Jenny Sequeira, who is an immunization and strategic technical advisor with the Geneva Learning Foundation. And then Charlotte Mbu, who's the acting manager also with the Geneva Learning Foundation. And with that, I will turn it over to you, Reda.
Thank you very much indeed, Heidi and Aaron, for this introduction. So next slide. In about 10 minutes, I'm hoping to provide a little bit of framing before we dig into what we actually learned about identifying and reaching zero-dose children through these EDLHX events. And you'll be hearing some remarkable insights and case studies, both from Jenny Sequeira and from the case study authors, zero-dose practitioners themselves. I want to try to give you a sense of the method and the approach that led to these insights. Next slide. So first of all, if you look in the first semi-annual update of the Gavi Zero Dose Learning Hub, and you'll find this update on zdlh.gavi.org, you'll see this statement: engagement with frontline staff through peer learning is powerful and can identify what works and how. That, of course, begs the question, is there a reliable, reproducible method by which we can, in fact, lead such engagement to really maximize the insights and get the highest return on this kind of engagement? Next slide. So as an example of the work that we've done as part of the Gavi Zero Dose Learning Hub, this series of 2 ZDLHX events, which were really events focused on sharing of experience between zero-dose practitioners, as you'll see from all levels of the system. Within 6 months, we grew a community of zero-dose practitioners from 0, as the ZDLH was completely new, to over 3,000. And you can see that not only the 4 country Learning Hub countries were represented through this process and joined and showed interest and contributed, but also, in fact, zero-dose practitioners from 100 countries. And on the right-hand side, you can see, as a point of comparison, a number of platforms which include some type of focus on zero-dose and the level of participation, both from the specific CDLH countries and the total participation. So in 6 months, this is the numbers we were able to reach. Next slide. Now, the next question is, well, okay, are we reaching the right people? So with the ZDLHX, you'll see that we reached 37% subnational, really district and local. You can see there's almost a quarter of the participants who came from the region or state level. A little bit over a quarter are actual national EPI planners also participating and contributing, and then 13% internationals, and 85% involved in zero dose. Next slide. So it seems like we've reached a fairly significant number of people directly involved in zero dose from all system levels to participate, to engage through peer learning and identify what works and how. And this, in a way, is the forest. This is a big picture. Jenny will be looking with you and taking you through the individual trees, specific case studies, and to see what exactly can we gain from this type of process. So the next question is, how did we do it? So at the Geneva Learning Foundation, we've studied the culture of immunization, and ran in 2020 and 2022. We performed 2 large-scale measurements and found that across a range of dimensions of actions, continuous learning is really the Achilles heel of how we learn in immunization culture. What that means concretely, you can see 5 specific things. 1 is relatively few learning opportunities. 2 is just limitations on the ability or for staff to experiment, to take risks, and with that comes a low tolerance for failure. Number 4 is a focus on task completion at the expense of developing capacity for future performance. And 5 is that lack of encouragement for learning. So this, we knew that if we wanted to foster learning about zero dose in order to better understand how at the local levels we identify and reach zero dose children in under-immunized communities. We needed to tackle this continuous learning dimension. Next slide. So at the individual level, we know a lot from the learning sciences about how to strengthen continuous learning. And so in reviewing these 6 ways in which we know we can strengthen continuous learning, we asked ourselves, well, how do we develop the ZDLHX initiative, series of peer learning events within the context of the Gavi Zero Dose Learning Hub, in order to strengthen that continuous learning? And we try to build in all 6 of these ways of thinking, ways of doing, such as motivating me to believe strongly in the importance of translating knowledge into action, or number 6, helping practitioners identify and overcome workplace obstacles. So through every step of the process, as we developed with the Zero Dose Learning Hub, with Gavi, the design of the ZDLHX, we asked ourselves, how can we actually make sure that the way we're doing it is going to be conducive to fostering continuous learning? Next slide. Now, across 4 phases of ZDLHX, I want to first highlight that the yellow bar, the experience, is actually the live event. But in fact, most significant learning through the ZDLHX process does not happen during the live event. It is the most significant amount of time commitment that we ask of participants, 90 minutes, but it's actually the component of ZDLHX that precedes and follows this experiential live event where we find most of the significant learning happening. And that goes to with the level of effort required for our team, for ZDLH, to analyze the incoming data as hundreds of practitioners share their zero dose experience, and after the event, share their reflections on what value this has created, what did we learn, and what are you going to do differently as a result. And then most amazing is that the knowledge translation piece, staying connected with fellow practitioners, figuring out what to do with what you learned, becomes a kind of self-sustaining cycle. And so a big investment upfront in terms of the level of effort required to set up and establish such a system, but really the benefit of peer learning is the potential for it to be self-sustaining. Next slide. This is just, for those who wish to know more, a paper about that process, really bringing together, in order to strengthen continuous learning, which we know is the weakest part of how we learn in immunization, is really combining peer learning, remote learning, social learning, and network learning in order to foster, to build an effective learning system. Next slide. So of course, the following question is, okay, does this actually make a difference? And here this is where we talk about measurement. Next slide. So we actually, in ZDLHX, we proposed a way to measure for individuals the creation of value in this intervention that can also be used in other types of interventions. So this, we looked at and we asked questions. Has this changed you as a professional? Has this changed your social connections? And so on. And we had a baseline from 2022 with over 10,000 immunization responses from immunization professionals, which then enables us to show, for example, that on most dimensions, ZDLHX as an event actually created more value than our baseline. And compared to other studies, this is a very high, this is just overall a very high level of value creation through peer learning. Next slide. Next is the question of how effective learning relates to performance. So of course, in this case, ultimately, it's about what we would call in education or learning science terms, mission performance, in immunization terms, improved vaccination coverage. And here we find, and this is the amazing part about the dimensions, the different ways to learn, is that we know that if we strengthen these different ways to learn, we can show that there's a strong correlation between improved learning and improved both knowledge performance and mission performance. You can see the effects here mapped across over 6,000 respondents. This is before the ZDLHX, but the same results apply. So what that means is actually a remarkable insight. Rather than having to demonstrate and prove that that improved learning leads to improved performance, we have a very large-scale study, as well as many other studies in areas other than immunization that consistently show the same thing. If you strengthen the different dimensions of learning, and especially if you focus on the weakest ones, you're likely to get a significant return on investment in both knowledge performance and mission performance. Next slide. So this is my final slide, is really, when we think about what we did with ZDLHX, and as right before we deep dive into the specific cases, insights, and what we actually learned that is likely to be of interest to technical specialists working on zero dose, the way we were able to so rapidly build an effective learning system is by combining three things. One is having a sense of the capacity for change, the environment, and identifying this continuous learning as the weakest dimension of it and targeting that dimension specifically. Second is making sure that we're creating the highest value possible for individuals and teams. And third is, of course, linking that back to actual health indicators, and then exploring to what extent that we can talk about attribution or contribution. My final slide is a kind of emblematic quote that really stood out for our team. Next slide. And it's this one: in response to the new strategies, I learned, this is an individual participant, from the Gavi Zero Dose Learning Hub, we are making a change. We're adapting the practices on top of the existing ones in our district. And then examples of very specific practices demonstrating, connecting the dots between the learning intervention and an actual change in practice that leads to a change in outcomes. Now we're going to deep dive from the forest into the trees with Jenny Sequeira. Jenny, over to you.
Thank you, Reda. And it's great to hear some of these examples of how continuous learning is really an important part of immunization. So as you mentioned, Reda, we're going to shift to focus on the case studies that emerged from 2 ZDLHX events that happened last year. And these peer exchanges were open to all, but focused on case studies that were submitted by immunization practitioners from the 4 country learning hub countries mentioned on the slide. And we saw, Reda, from your slides, that over 700 health workers submitted their own case studies. And what emerged organically was this rich tapestry of zero dose and under-immunized intervention examples. We could only, unfortunately, feature and hear directly from a fraction of those case studies during the ZDLHX events. And now in this webinar, we'll unfortunately only hear a few, even fewer of the direct stories. But we wanted to highlight that the variety of case studies are in the X reports, which were posted in the chat. So if you want to look at more of those case studies in detail, please look at the chat link. Reda, you mentioned several times the importance of continuous learning and how it's the Achilles heel of immunization. And I believe this is especially the case in locations with persistently high numbers of zero dose and under-immunized. As a global practitioner in immunization, I'm very interested in learning how we can apply continuous learning to areas that face challenges with equity. And so the ZDLHX events last year were an attempt to use the power of peer learning and digital learning to advance how zero dose knowledge is translated into action at the front lines. Let's go to the next slide. So the peer exchanges in 2023 focused on Bangladesh and Mali in May, and Nigeria and Uganda in September. Those topics in May looked at, first of all, that first part of the IRMA framework of identify, reach, measure, monitor, and advocate, that idea of how do you find clusters of persistently missed children in communities? And also, how do you look more at community engagement? This is something that we have not done well in the past, and the pandemic really highlighted the need to work deeper in community engagement. So that second topic in May was about consistently finding and then vaccinating children in urban, rural, remote, and conflict-affected areas. The event in September focused on how can we use integration to maximize opportunities to reach zero dose and missed communities, and how can we make sure that we're revising microplans on a continuous basis to better address the zero dose challenges. So on this next slide, we're really refreshing ourselves on the IRMA framework. If you're not familiar with it, it's Gavi's framework for looking at how to identify, reach, monitor, measure, and advocate for zero dose. But it's meant to convey a sort of a flow, not looking at one example in isolation with identify, but how a topic can start off with one area of IRMA and then continuously go into other topics. And in the ZDLH-X events, the case study around microplanning was a great example of this continuous cycle focus, where during the course of a year, you identify, then you work to reach, then you go back to identify, you're monitoring and measuring your progress, and then you're advocating for issues that relate to equity challenges. So we just want you to keep in mind the IRMA framework and how the case studies really nicely reflected how they work through the different components of IRMA. On this next slide, we don't expect that you'll be able to hear, or be able to see and read all of this really tiny lettering, but this conceptual framework is what we developed after the ZDLH-X events as a compendium of insights to really illustrate this forest that Reda talked about, of many different examples that came out from the subnational health workers on things that relate to identifying zero dose, things that relate to reaching zero dose. So we've built out a compendium that focuses on each component of IRMA, starting with identify, and the next slide will show you how we're doing the same thing with reach. But we wanted to highlight that these illustrations are one point in time. So you can find an example that starts with identify, moves to reach, moves to monitor and measure, or might start with reach because you've already done the identification, but then you're going to the other areas. So during today's session with the case studies, we're going to double click into some of those trees, but this is just a snapshot of that forest before we go into the trees. So let's go to the next slide. We wanted to just highlight that the case studies are showcasing direct, unfiltered stories from subnational immunization practitioners. And we know that there's many other types of evidence. The pro-equity evidence mapping that FHI 360 did with Gavi gives a global review, global examples of some of the rapid reviews that were done recently to look at evidence and effectiveness of approaches to reach zero dose. And we encourage you to look at those pro-equity evidence briefs. The topics today and what we looked at in the Zero Dose Learning Hub exchanges connected to some of these topics, like how do you leverage women's groups? How do you use community health workers? How do you maximize microplanning so that it really addresses root causes? So if we go to the next slide, we'll start with a quote that moves into the case studies, which highlights the concept of how in the past immunization has focused on things like hard to reach, which we tended to fixate on rural, remote, and geographically isolated. And what we're doing now as we move into more of the discussions with zero dose and under immunized, we were recognizing more and more how nuanced the zero dose really are, how much more we're finding zero dose in urban areas, and some of the zero dose and under immunized who are actually geographically close to health facilities. So this highlights how one health worker said, I learned that zero dose children are not just in rural underserved settlements, but also found in urban and peri-urban settings. On this next slide, we have a summary of the case studies that we're going to feature today. And these 4 topics came from the 2 ZDLH-X events. We'll probably only get to the first 2 topics, and it will depend on which speakers from subnational areas have good enough internet and phone connections. So we'll be adjusting as we go, depending on connections. It might feel a bit chaotic, but we hope that you'll stick around for the ride. So let's go into the first topic of microplanning. Thank you. We had 4 really interesting case studies that we wanted to highlight today. And we wanted to start with this first case study from Nigeria in Sokoto State that highlighted how to reorient microplanning to better address local zero dose challenges. We received so many submissions about microplanning that really highlighted nicely this idea of working with the communities to get really good root cause analysis of what the challenges are in the communities. We heard about lots of behavioral insights that are being used for microplanning, and lots of studies that looked at how the revision was just the start of how a microplanning is done, and then the readjustment of those plans that dig deeper into local root issues over the course of a year. Many of the submissions kept highlighting that issue of continuously revising your plans, which we equate with a type of continuous learning. So we thought that the microplanning was a great segue into that concept of how do you promote continuous learning at the district level, at the health facility level. Our first speaker who was scheduled to present today was Aminu Ibrahim Yaya from Sokoto in Nigeria. But we were very saddened to hear that Aminu passed away on January 14 after a short illness. If we can look at the next slide, we just wanted to say he was a star of the ZLH-X2 event and a dedicated immunization practitioner. His wife and his colleagues in Sokoto have sent this tribute to a true vaccination hero. So before we go into some of the other case studies, we wanted to just give a short moment of silence for Aminu Ibrahim Yahya, and we wanted to send our deepest condolences to his family and to his colleagues in Sokoto. Thank you. So let's move on to the next case study, which features a health facility in Uganda. And we're going to be talking with Muhangi Ambrose. And Ambrose and his colleagues in a health facility were doing everything in their microplan. They had planned immunization sessions and they were conducting them according to the plan. But their immunization coverage was still lagging and they didn't know where the problem was. And so they used in Uganda, their Reaching Every Child microplanning tools, and they refined their service delivery approach with community health volunteers. They decided to really interact with their village health teams, which were the community health volunteers in Uganda. And they tried to better understand the zero dose and under-immunized children living both near their facility and far from the facility. So they worked with these VHTs to line list all the under ones and in the catchment area. And then they looked at that list of under ones and they talked to their communities. They used some behavioral tools. They used some tools that looked at the 5 whys, which Ambrose will talk about a bit more. And they decided to increase their static or fixed services from 1 to 3 times a week and their outreach from 2 to 4 times a week. And they had the ability to do that. They mapped out all of these outreach sites with the villages and the village health team mobilizers. And then they worked with the mobilizers to help them do a follow-up list after each session immunization to track those who didn't come for their appointments so that they had an ongoing updated list. And then they decided to do quick weekly reviews and more in-depth monthly reviews to make sure that what they were doing was on track. Importantly, they revised their microplan every quarter. And I want to turn to Ambrose now. And if Ambrose, you can turn on your mic and introduce yourself and tell us a little bit more about your case study and how you know that what you're doing is successful with reaching zero dose and under immunized in your catchment area. Over to you, Ambrose.
Thank you, Jenny. Good evening, everyone. I am Ambrose Muhangi from Uganda. I work in the Southern District of Isingiro District. About this approach of microplanning is actually when I was writing this for this webinar, I was quite interested in sharing all the insights because over the time we've been trying to share a few of the best practices we are doing, and at some point they don't feature up in these kind of meetings or interaction with different kind of people. So microplanning, I think, is the way to go for us in Uganda, and it is here and it's going to stay if you want to achieve the targets and pull your coverage from the 50s to maybe probably 80 and 90. To dig down into the approach, as Jenny has highlighted, these are the kinds of interventions we wanted to put in place, and actually they are the ones in place as of now. Basically, one, we were at around 79% coverage in BCG, in terms of BCG. And this prompted us to think and ask ourselves, why are we not hitting the target? We are going for outreaches every now and again, but we're not hitting the targets. Because our first question was, why are we not hitting the coverage? Then the second question, actually, from answering why not hitting the coverage, we came up with the answers because we looked at, maybe we didn't know where the children are. That was one of the answers from the first why. And two, we didn't know which children we are looking for, as in numbers. That was also another question. So we came up with this intervention. Let's first line list all the under ones, because this was our priority target group. He said, let's line list all with the help of the VHTs from all the villages. And we did this in a period of, I think it took us like 2 weeks, because we had to facilitate with some kind of remuneration so that the activity can be done very fast. So from the line lists, then we asked ourselves, then we have the children that are existing in the community. Where are we not reaching them?
So
this was
Ambros,
our
I
second
know
question.
we have
So
limited
then,
time. Yeah, so I'm wondering, Ambros, sorry to interrupt you. Could you tell us a little bit about how you use the 5 Whys tool and how you were able to work at revising your microplans? Because we've done a quick review of the details of how you did the approach. We want to know a little bit about the microplanning process itself with the 5 Whys, the revisions each quarter. Can you tell us a bit more about those aspects?
thank you, Jenna. Yeah, that's what I was trying to narrate about how we came up actually from answering the questions under the 5 Whys. This is where we are getting the answers on what we shall do. What shall we do is our micro plan. Because if you first know your coverage from line listing, then it sets you to thinking of how many sessions do you need to conduct in order to get the number you want to achieve these targets. So when we did that, after line listing, we found out we had a big number in the village, but compared to the number that was coming up for immunization, that's how we thought of increasing our sessions. Remember, I said from the static sessions or the fixed sessions at the facility, had to increase them from 1 to 3 in a week. Then our outreaches from 2 to 4. Actually, this was one of the best strategies. Actually, for us, our micro planning was based on around, I think, 4: service delivery, advocacy and communication, availability of supplies at the facility, then maybe data use and data quality. This is actually how we are trying to get to this. So from the line list, we had to come up with fixing up all sessions in our micro plan. Then we introduce something to do with follow-up after the sessions, tracking of the defaulters or missed appointments. This is so keen and so crucial. But the syntax that lies here, the challenge is, you can make line lists, but if you don't provide some kind of airtime or something to help with communication, still you will not get these children. Because now here the mobilizers, you just produce lists to mobilizers, but you don't give them airtime for coordination. That's why I'm talking about a concept about communication. So if you want to instill a practice, at some point you must be ready to pay the costs. So here we provide a little bit of airtime to these mobilizers to follow up on these missed appointments in our sessions. So from there, actually, we said, now we've done all this. Then why is our data not coming up very well? So we said, one, let's first conduct quick weekly reviews of our data to see if you went in the field and vaccinated, or you did all the sessions in a week, then at the reporting time, you find you've reported 2 children, 3 or 4. But when you're trying to balance the vaccines, you find the vaccines, you've overutilized very many. So meaning data is getting lost in the process before it reaches the system, the DHIS and the monthly report. So as a district, it had introduced some of the initiatives like tracking this data, the weekly data on Google Sheets for every facility. So we maintained this as a best practice. Then as a facility, we agreed to still conduct monthly reviews to validate this data, not just punching data into the monthly report and then sending or uploading onto the DHIS2 minus reviewing it. This is not accepted in our facility. At the end of the month, we sit as a team, EPI with our mobilizers, we sit to review. From the outreaches, we conducted 4 outreaches. Week 1, this was the output, outreach 2, this was output, outreach 3, and this and this. From the start sessions, we got this. Are these the actual numbers that we had? We agree as a team, yes. Then when we find there is any kind of error, then we correct that. Actually, there was some kind of hindrance with the reporting tools and how data was being captured, but it was harmonized. We are doing some kind of pilot of smart paper technology so that everything just have the sessions conducted on smart paper. At the end of the day, you scan the papers, it uploaded to DHIS2 directly. But this one, I think it didn't become reliable, so had to stick back to the registers and whatnot. So leaving that one aside.
So Ambrose, can you just wrap up? Can you wrap up very quickly, because we need to move to the next case study, but we'll have time to come back to you with questions during the Q&A session.
I think I'm talking about the last thing.
Okay.
About revising the micro plans. Incidentally, it's not that we revise micro plans quarterly, but we actually review the performance. We don't revise, but you review. Actually, after reviewing, you set new targets. If in the first quarter of the year you did not hit the target, then it consequently means that you must reach this target in the second quarter. That's why we come back to review our micro plan and see at a quarterly basis, where have we reached and where do we want to go? I think that's what I want to talk about. Thank you, Jenna.
So much. Thank you, Ambrose. Thank you so much for sharing. And we'll come back to you with questions at the end of the session. So we'll go now to the next slide. To wrap up on the microplanning, we had a quote from one of the ZDLHX events, which said, "I now think that healthcare interventions should include microplanning with community leaders, religious, and other stakeholders in the community to ensure that real issues or barriers are identified and the intervention are community supported. So this ensures sustainability, and this is what I will now do differently in my work." So thank you, Ambrose, for highlighting the importance of not just microplanning once, but going back and revising and reviewing your data and thinking about how your interventions are addressing your challenges on an ongoing basis. So moving to the next topic of integration, these are some of the case studies that came out of the second ZDLHX event. And a lot of the topics that health workers were talking about revolved around integration. And we, those integration topics were specifically trying to address challenges where caretakers of zero dose or under immunized had at least one touch point with health services, but those children remained under vaccinated. So the challenges here are addressing how can the health system maximize opportunities to reach children who have had at least one touch point with some type of health service in their area. Our first speaker is Abubakar Muhammad Amali from Sokoto State in Nigeria, and his case study very nicely illustrates moving from a global missed opportunities in vaccination strategy that's then endorsed by the national level by the Nigeria Primary Healthcare Development Agency, and then adapted at the local situation in Sokoto. Other case studies in integration highlighted things from, like examples from Scovia Okello in Uganda, where she had a brilliant use of ANC data, antenatal care data, around expected delivery dates and subsequent follow-up of children delivered at home who were not being brought for vaccination. So let's move to the next slide and to Abubakar's case study. So in Sokoto, there are a lot of zero-dose children, and we can hear more about that from Abubakar. And these children, many of them were missing opportunities for vaccination when their caretakers or they themselves came for other health services, such as treatment of malaria, antenatal care, family planning, or nutrition. And so Sokoto used the missed opportunities in vaccination strategy to adapt a local approach called Missed Opportunity and Service Integration Strategy, or MOSIT. And this was to ensure that any child who was present at any other PHC service would get vaccinated during that visit. And so here's a quick overview of the steps that they went through, and then we'll hear more details from Abubakar. So in the large facilities that have concurrent services and in hospitals, when clients came to the front desk, the desk officer screens them to identify other services they may be eligible for. And this include children accompanying the client. The front desk officer then registers the clients and puts any other services that are eligible for in a service integration register, and then gives them a referral slip when they go to those services. So when they go to see the health worker provide the services they came for, that health worker asks if they have a referral slip. And if they do, then the health worker refers them to where to go for the other services, including immunization. So let's turn to Abubakar. Are you in the room, Abubakar? If you are, please unmute. Charlotte, do we have Abubakar in the room?
Yeah, he's here on the panel. Jessica, please, can you prompt?
Yeah, sorry, I have issues with my connectivity.
Okay, we understand that, Abubakar. Thank you so much for joining. Can you quickly introduce yourself and then tell us, how do you know that this MOSIT intervention in Sokoto is a promising or successful approach for addressing zero dose or under immunized?
Yeah, thank you very much, Jenny. I am Dr. Abubakar Muhammad Amali. I'm the routine immunization focal person from WHO Field Office, Sokoto, Sokoto State, Nigeria. Through this MOSIT strategy, we were able to improve our performance in identification and the tracking of priority settlements, because after every session, since we do register children by settlements, so we try to harmonize the data and also prioritize those settlements for follow-up visits. So we're able to identify and also track those priority settlements having those children, and also the health facilities that have proximity to those settlements, and also be able to identify which wards those settlements are, so that we can be able to have a comprehensive list of the settlements and the wards vis-a-vis the children that we're able to track, and also those children that we're able to vaccinate. And through that, we are able to vaccinate many children using the strategy of the most.
Great, thank you. I know that there'll be lots of questions for you, and I know that we're running short on time. We want to leave the audience with some ability to ask you questions. So we'll stop right here, but please stay on the line. When we get to the Q&A session, we will come back to you with some questions. So thank you, Abubakar. Sorry, we didn't have a whole lot of time to go through the details of your case study. We can, if you want to read more about the details, that's in the ZDLHX report that was shared in the link in the chat. Let's go to the next slide, and just to quickly summarize, let's move forward. We had another of backup case studies. Keep going. We'll go to the summary of discussion with case study speakers. Thank you. So we heard today very briefly from two of the case study authors, and we wanted to leave time for you to ask some questions to them or to Retta or to myself. We wanted to make sure that we highlighted the link of continuous learning with peer learning and the ZDLH-X events that occurred last year. And thank you for your time. Handing the mic back to Heidi and for a Q&A session. Thank you.
Sorry, Jenny, I missed.
Yes, sorry, Abubakar, we'll be going to the Q&A section where people may be asking you questions about your case study. Thank you.
Yeah. All right.
Great, thanks, Jenny. And thank you, Ambrose and Abubakar. We do have some questions. I think what I will do is I will start with Abubakar. There's been a couple of questions, I think 3, and then I will read them and then turn it over to you. And if you can answer those, I will then also leave time also to direct some questions to Ambrose. I would like to, in general, highlight for the audience that I think what some of these questions exemplify is some of the power of that ability to have an exchange between the people who are implementing actually these interventions and understanding how they're working and being able to dig into a little bit more of the details. So it does help to demonstrate how we can learn from having more visibility on these approaches. Okay, so for Abubakar, there were 3 questions. Hopefully, if I miss one, Aaron will let me know. But one question is, how do you ensure children with vaccination referral slips don't leave the health facility or hospital without getting vaccinated? That's one. The other is, if there are zero-dose children who come to the facility or hospital who are over 1 year of age, what do you do for the antigens they have missed that are in the schedule for the under 1-year-olds? And the third question is, you highlighted the importance of contextualized tools for microplanning in the country. Sorry, it is for Ambrose. Excuse me, I'll save that for Ambrose. So Abubakar, those are the 2 questions. How do you ensure they have vaccination before they leave? And what do you do for children who are over 1 year of age but have missed antigens?
Yeah, thank you very much, Heidi, for these questions. The first questions that you asked about how do we ensure that those children are vaccinated before they leave the hospital. If you look at the intervention we have proposed, where we are conducting the MOSIT strategy, meaning missed opportunity for service delivery and service integration. What happens usually at the reception of each facility, there's a front desk officer, so that each child that come into the hospital, he's been screened before he entered into the facility to know which service the child is eligible for. So through that, through the questions, the receptionist will now understand whether the child has been immunized before or not through the screening process. So those services that the child is eligible for, he is being directed depending on the capacity of the personnel in the hospital. There are facilities that have more than one service providers. So in that case, we do point care, whereby each child will be referred to a point of care where he will access a particular service. Then for those facilities that have 1 or 2 service providers, I mean, where they have the shortage of personnel, usually those service providers are the ones that offer multiple services. So the child is being given a referral sheet and he's been directed to where he's going to get his service. So before he entered the hospital, the receptionist, the desk officer, the front desk officer will screen him and ensure that all those services, including immunization, that he's eligible for, he gets them before he leaves the hospital. Then number 2, about the those children that are more than 1 year. Usually now we have even upgraded to under 2 years, because we have measles 2 vaccination. So those children that are even over 1 year still come to immunization to receive, second dose of antigens that are given 15 months or thereafter. So even if the child is more than 1 year, there are still some antigens that is eligible for that he will be
We may have lost Abubakar. Are you still? Abubakar, I don't think we can hear you very well. We might, can we mute Abubakar and I'll ask some of these other questions and then we can come back to you.
hello?
Hi, yeah, you were breaking up a little bit. Would you like to finish your answer and then we'll move on to a question for Ambrose.
Sorry, I'm back, Heidi, I'm back.
Yeah, you're back.
Yeah, I don't know whether I was able to touch on your questions.
Yeah, we heard most of it. So let me, how about this? There's two things. One is that there are a few new questions in the Q&A, which if you want to go in there and
Okay.
look and type, there's at least one for you. And then let me try to pose a couple of questions for Ambrose. There were quite a few that came through. One of the things that I will note for the general audience is that I think we're going to end up with more questions that we're going to be able to answer in the time allowed. So one is that there is more information in the report, the Zero Dose Learning Habitats report that is available now. But also we will work on answering these offline and then sending those around with the slides and the recording. All right, Ambrose, for you, one of the questions is, which of the tools besides the 5 whys have you found to be the most helpful in going deeper into your microplan to understand and then address root causes around zero dose children or groups? And then there is another question, which I'm going to kind of combine, which is related to the effectiveness of this microplanning approach. And how did you know that your work to improve the microplanning approach increased coverage, particularly of Penta 1? So how did you know the rate of zero dose infants being vaccinated after identified? And what did you find to be the barriers that those children were facing to not have been previously vaccinated? Ambrose, if you're still online, maybe you can touch on those two questions.
Thank you so much. I think I will begin with the last one about coverage of Penta 1. Previously, my coverage of Penta 1 was at 80%. And after micro-planning and finding out the number of children I am supposed to reach 2, and with those interventions listed above or we discussed, it is now at around 88. This is for Penta 1. And what basically I can say about this, it's just understanding how many children do you need to reach in a year? Where are these children? Where are they located in the community? And how to get these children? And who will help you to get these children? These are actually the questions you need to ask yourself if you want to achieve coverage. I think this has been the best approach in this sense. Then the other thing was about the tools, apart from the 5 whys. I highlighted about line lists and defaulter tracking tools. And I talked about something to do with Google Sheets to monitor the weekly performance of the outreaches. And I talked about something to do with monthly reports. Actually, it should be talking about accurate. So tailoring all this brings us to something like what we have in the system. The DHIS2, this is the system where we report all that we do in facilities that goes up to the ministry level. And with the help of the biostats or the data clerks at the facility, they are able actually to generate for you how far you've gone. Midway, anywhere you need, as long as you've just done anything. These people can help you to extract this data and put it back into such kind of like you present it into like graphs or cumulative frequencies. And these ones help you to actually monitor your progress. And in most cases, we usually have these graphs on the walls to plot. If you set targets, you know, this month I covered this, then you just plot a cumulative kind of graph. And this one also helps to monitor. I think this is what I was trying to mean. Hope the question is answered. Any other more questions for me?
Yeah, there will be. Just if you have a few minutes, what we'll do is we'll go over by just a few minutes if you can. If you can't, we totally understand. And then, as I mentioned, we'll follow up and try to get some of these other questions answered. So there are a couple of questions about that could be targeted to both Ambrose and Abubakar. So for one is related, again, to sort of the resource intensiveness and cost effectiveness of these interventions. If you have any idea about that. And then also there was a related question about, you know, how the interventions depend on the capacity and the morale of the local health workers. If you could comment on that as well. And then I think there was an interesting question about how these interventions may or may not be useful in the context of populations that are migrating and may not be in a fixed location. So maybe what I'll do is ask Abubakar to try to tackle a couple of these conversations, and then Ambrose, I'll come back to you. Abubakar, are you still able to, you're online, I see, but you may still have connectivity issues. There you go. You're open now. Go ahead.
Sorry, my connectivity has been on and off. Please, I want to get you clear.
Yes,
I was able
hear.
to respond.
Yeah.
I was able to respond to some of the questions in the Q&A. I don't know whether there are new questions. I've responded to some in the Q&A.
Okay. I was wondering if you had any additional information about sort of cost effectiveness or resource intensiveness of the intervention, how they work, how the morale and capacity of health workers affect the implementation of these interventions, and then if you have any comments related to populations that are migratory, that may be moving from place to place and not accessing fixed services.
Yeah, actually, for this intervention, we'll be leveraging on other interventions because, like, we do have in-between round activities. We have budget for in-between round activities and routine immunization in form of RI intensification is captured, and also some other services that have been conducted. So for the most that we have, we never needed additional money to that extent because we have activities that are being conducted, so that through that we use the opportunity to carry out this intervention. So it has been very cost effective because there was not too much demand for money, and currently we will look at and see whether we can still leverage so that we can expand on the, how we can improve our coverage and the reaching of the zero dose children.
Thank you, Abubakar.
Yeah.
Ambrose, before we close, do you want to offer any additional comments or answers to some of these questions?
Maybe if I could talk about, there's a question I saw that I really want to talk about. I think it was in a proverb. I'll probably see it. I saw something to do with why are we having beautiful coverage
Hmm. And still outbreaks. Yeah.
and facing up outbreaks. I think outbreaks and the coverage, of course, at some point they go hand in hand. But the best response I can put is, as long as people actually mostly like us in Uganda, the outbreaks that are common are for measles. So meaning people are not fully immunizing these children after the Penta 3. Most people tend to lose track of these children because they are going to spend 3 months without coming back to the facility. And this one now goes with advocacy and communication. The behavior change communication you put across. And actually, what do you teach the clients? Do you tell them the importance of returning back? If there is nothing of that kind, then that means at the end of the day, the coverage at some point will be good, but there are outbreaks that will happen. Maybe that's what I will talk about.
Great. Thank you. Wow. Well, this has been a very rich webinar with a lot of good information. And I really am grateful not only to the Geneva Learning Foundation, but to our participants who submitted the case studies, have participated in these learning exchanges, and now here today sharing their experiences and answering questions. It really adds quite a bit of depth to what we're discussing. As you've probably seen now in the chat, the recording and the associated publication is available on the Zero Dose Learning Hub website, zdlh.gavi.org. And the recording will be there as well. We also hope to follow up on some of these outstanding questions that we might not have been able to get to, but to point to that the publication does have more information in there. And again, just really thank the Geneva Learning Foundation for presenting the results of this work and underscoring the value of having the time for these types of conversations to really understand what are the barriers and what's working, to reach zero dose children, and then be able to have the time to clarify and answer questions from other people who are in the same, working on the same issues. So stay tuned. There will be many more results coming out of the Learning Hub countries. Hopefully this is just a taster. There will be a series of webinars this year. And we do have already the next webinar planned for the 29th of February, where we will be joined by our colleagues at FHI 360, who will be going through the case studies that they conducted. There are 6 of them. They're already on the website, but I think it'll be really interesting to hear more about those case studies, reaching zero dose children, but also some of the methods that were used to implement those case studies. And with that, I will wish you all a great rest of your day. Thank you for joining, and hope to see you again here soon.
Thanks, Heidi. Thanks, everyone.